Good afternoon. Thank you all for joining us today. We really welcome you to this important webinar. My name is Konstantina Paraskeva. I'm a gastroenterologist. I'm the current president of the Hellenic Society of Gastroenterology. Together with my dear colleague, Mr. Yannis Virlos, General Secretary of the Greek Society of Koloproktology, we will moderate this webinar. This is the first time in a two-part series focused on significant polyp and early rectal cancer, briefly called SPERC lesions. For the first time, the two scientific societies have joined forces to organize these webinars aiming to address a critical area in colorectal disease management. Why this focus is important? Because published data clearly indicate that there is a variation in practice, both of under-treatment and over-treatment. Therefore, there is a need for standardization in clinical practice. Our goal is to promote a multidisciplinary approach, bringing together leading specialists to share insights and experience in the assessment and management of SPERC lesions. We encourage all participants to submit your questions in the Q&A section. And without further ado, I would like to invite my esteemed colleague, Mr. Yannis Virlos, to offer a brief introduction and set the scene for today's webinar. So, Yannis, please.
Thank you, Konstantina. So, without further delay, I will start my introduction. Do we have the Theophilos? Can show us the slides?
Ναι. Την παρουσίαση, κυρία Παρασκευάτζη, δεν είναι?
Ναι, την παρουσίαση του κυρίου Βίρλου.
Yeah.
Του κυρίου Βίρλου παρουσίαση δεν έχω. Έχει στείλει...
Γιάννη, εσύ μπορείς να κάνεις share screen?
Brown.
Ναι, όχι, έχει στείλει και ο κύριος Βίρλος μια παρουσίαση δικιά του.
Δεν έχω πάρει εγώ κάτι γι' αυτό.
Γιάννη, εσύ, John, can you do a screen share? Or maybe I could help with...
Do you have my presentation?
Yes, I will immediately send it to Theophilos right away.
So,
Theophilos.
While we wait, I will just
Theophilos, I sent you the...
Sure. I will present the speakers for today's webinar, which is Dr. Giadzios, gastroenterologist at Konstantopouleio Hospital in Athens. He will talk us about the optical diagnosis of SPERC lesions. Then followed by Gina Brown, professor of gastrointestinal imaging at the Imperial College of London. And last, Nick West, professor of gastrointestinal pathology at the University of Leeds in the United Kingdom, will tell us about the pathological assessment of these lesions. At the end of these presentations, we'll have the pleasure of having today the professor of surgery, Mr. Bill Hild, who is also the chairman of colorectal program at the São Paulo Foundation in Lisbon, Portugal. Professor Hild has been really visionary and helped many patients in his career by introducing the concept of total mesorectal excision, which really drops dramatically the recurrence rate for rectal cancer from 50% to 5%. And hence, many patient lives were saved, and families and patients are grateful to him, and the whole surgical community is grateful to his contribution. And as we can see, he's still active and we're so pleased and lucky and fortunate to have him today. So let's hope that we can see the presentation. Okay. So how can I move it downwards?
Θα πρέπει να το κάνετε εσείς share screen αν θέλετε την παρουσιάσετε. Εγώ την άνοιξα για εσάς.
Okay.
Αλλιώς θα πρέπει...
Maybe Theophilus can move it around. It's not.
Okay.
It's a short
Yeah, okay.
presentation.
Okay. So next slide.
So
Next slide.
next.
Next slide. So widespread adoption of bowel screening has led to the incidence reduction and mortality reduction of colorectal cancer. And on the other hand, this has led to steady increase in the detection of precursor colorectal polyps. The vast majority of these polyps are small and can be removed safely and excised by standard endoscopic polypectomy alone. Next slide. So it is true that only a small part of these lesions are big in size, and up to 5% of colorectal polyps are equal or larger to 20 millimeters size and non-pedunculated. Next slide. And next slide. And some of them, they need advanced endoscopic techniques for removal, including ESD and EMR. Next slide, please. To make matters a bit more interesting, up to 15% of these complex lesions can harbor malignancy. Occult malignancy and polypectomy alone can be a suboptimal treatment. Next slide. And then there is a dilemma on the optimal management. On one hand, alone endoscopic resection can be an undertreatment, whilst surgical resection of the colon and rectum as an alternative can achieve a definite excision of a significant polyp and potentially optimal oncological treatment for unexpected polyp cancer, but is associated with high morbidity and mortality and cost, and can sometimes be an overtreatment for lesions that are benign and increasingly amenable to less radical therapies. Next slide, please. These issues raise challenging decisions about the optimal management of significant polyps, resulting in variations in treatment and outcomes. Next slide. Borley and Wheeler in 2011 have introduced the term of significant rectal neoplasm, whilst British Society of Gastrenderology and Association of Coloproktology of Great Britain and Ireland in 2015 published joint guidelines for the management of large non-pedunculate colorectal polyps, which are non-pedunculate colorectal polyps larger than 2 centimeters. Next slide. So subsequently, Brenda Moran from Pelican Cancer Foundation introduced the term SPEC, which is significant polyp early colorectal cancer, defined as a large 20 millimeter or more generally sessile lesion, which is morphologically aberrant and not straightforward.
Παρακαλώ, μπορείτε να κλείσετε τα μικρόφωνά σας, αν έχετε την καλοσύνη.
Which is morphologically aberrant and not straightforward to access endoscopically. For this lesion, polypectomy may be unsafe or may result to incomplete excision. Next slide. So SPERC, on the other hand, is a significant polyp early rectal cancer, a lesion that is located in the last 15 centimeter of the bowel, which is the rectum, and which is divided in 3/3. The lower rectum encompasses the last 6 centimeters, and any low rectal lesion is at or below the origin of levator A9 on the pelvic sidewall. And for the mid-rectum, the distance is 7 to 11 centimeters, and for the upper rectum, 12 to 15 centimeters from the anal verge. The measurement of tumor location is typically measured with a rigid sigmoidoscope in a awake patient, as well as by an MRI. And the important advantages to the approach of SPERC compared to a colonic SPEC is that the endoluminal access is easily feasible by a number of modern endoluminal techniques, including endoscopic ones such as EMR and ESD, as well as surgical ones such as TEM and TAMIs. And notably, these interventions will be the theme of the second webinar that will follow this one. And a SPEC lesion also is surrounded by the mesorectum, which allows safer and deeper full-thickness resection, apart from the area located anteriorly above the peritoneal reflection. Next slide, please. So the variation in the management of these lesions has created the need for multidisciplinary approach and regional networking in order to standardize practice and improve patient outcomes. And this had as a consequence a SPEC program, which was developed and funded by the Pelican Cancer Foundation as a regional delivery workshop for colorectal multidisciplinary teams in England and Wales. Next one. Lastly, I will provide just a snapshot of the MDT implementation for the management of SPERC lesions, which was published in the Disease Colon Rectum in 2022 by the Basics group. And we can see that most of these lesions were treated by endoluminal techniques, endoscopic or surgical, leaving a small proportion of these lesions to major surgery, and hence resulting in high organ preservation rate. This highlights the importance of MDT role in decision-making and outcomes improvement by sparing patients from unnecessary major surgery without compromising oncological outcomes. Next one. Closing this presentation and introduction, it will be an omission not to mention that factors related to SPEC or SPERC lesions represent only one part of decision-making. Fitness of patient circumstances, and most importantly, patient preferences often determines appropriate intervention management. Thank you. Konstantina, back to you. Konstantina,
the speaker.
Sorry again, thank you, Yannis. Thank you very much. I would please like to kindly ask you to turn your microphones off so we can
Sure.
just. So following this kind introduction, I will introduce our first speaker, Dr. Giadzios, who is, as Yannis said, gastroenterologist at Konstantopoulia Hospital and an expert in ESD. Dr. Giadzios will present a lecture on optical diagnosis and assessment of SPERC lesions. Please note that each lecture will last approximately 20 minutes. And George, the floor is yours.
Hello, everybody. Good evening. Thank you for this very kind invitation. I'm sharing my screen. Hopefully, you can see now my PowerPoint presentation. Okay. So, I'm really happy to be on board and with you for these presentations. What we see in these pictures are colorectal adenomas, is the lesions that we see and we encounter in everyday clinical practice. But most of them are benign and are small in sizes, so they can be easily treated. What we learned all this year is that by removing these colorectal adenomas is that we break this vicious cycle of a colorectal adenoma progressing to colorectal cancer. Hence, in this way, we save our patients from developing colorectal cancer. And the good news is that most of these polyps are small in size, are less than 5 millimeters, so they can be removed safely and very easily through a cold snare polypectomy. The problem is that approximately 15 or 20% of our patients will have these kind of lesions that are bigger than 20 millimeters, and they can occupy at least 1/3 or 2/3, or perhaps come at a circumferential lesion around the rectum or in other places in the colon. So the problem is that these lesions give rise to this definition about SPEC and SPERC. And the problem is, of course, that in about 1/4 of them, they contain foci or invasive malignancy. So what to do and how to approach this lesion is really very important in the everyday clinical practice. Dr. Virus already said about the differences between rectal and cecal and colonic SPEC, so we don't have to do anything about that. What I would like to focus is that different lesions come at different sizes, and different sizes means that there is the possibility of deeper submucosal invasion, making our endoscopical approach, our surgical approach, dependent on how deep this submucosal invasion goes, because at the end of the day, this will affect the outcomes of our patients. And of course, the deeper the polyp goes, the deeper the invasion, then the more difficult it is to remove it. And of course, this deep submucosal invasion is because due to the risk of lymph node metastasis. And we know that from previous data that all these risks come at different sizes for each segment of the GI tract. And of course, for the colon, it doesn't matter if the lesion is in the upper submucosal invasion or it is lower, because it changes really the potential of lymph node metastasis. I'm not going to discuss about Kikuchi classification or anything about histological data, just to show you how the risk increases from 3% practically to 23% as the deep invasion goes deeper. And when we see a large polyp, when we see a SPEC or SPEC, this is the first steps that we have to take in account. We have to see the size, the location, and of course, assess these macroscopic and microscopic features of the adenoma, because they will be the first just to assess and see how can we treat these lesions. So when we see these large lesions, it doesn't depend on the size, but it has to be photographed, and we have to take videos from them in order not just to see its size, but in order to see how much and how difficult these lesions can be during removal. When we see a lesion, the first time what we endoscopists usually do is use this Paris classification. It is really a nice example of how a simple classification can really have impact on our endoscopy report and of course for our patients, because lesions that have deep elevation, deep central depression are usually the ones that they are malignant and should be treated accordingly. So this Paris classification is just not for a fancy tool or just to include it in an endoscopic report, but it has a strong correlation with the risk of submucosal cancer. So the next time we see these kind of lesions, we have to pay attention really to all the macroscopic features. Other features like non-lifting sign, like the chicken skin scarring or edge retraction or the spontaneous bleeding, have low sensitivity and low specificity, so we don't have to take them account when taking a lesion. However, besides and behind the Paris classification, there are also a subclassification of the large LSTs, these large lateral spreading colonic tumors and rectal tumors that come in different sizes and of course in different places. And we have to use this classification not just to use them in everyday practice, however, because by using this classification, we know how dangerous is the polyps that we have in front of us and how perhaps we are going to treat it. And of course, not only the size or the morphology of the polyp plays a significant role, but also this location, because we know that polyps that go to the rectum and perhaps polyps that have a large protruding like this bulky lesions have higher malignant potential, so they have to be treated accordingly. So the next thing is that now we have taken a greater overview of the polyps. Now we have to get closer and see the vascular and the pit pattern. We have to assess these two features, these microscopic features, just to get the most detail about the colorectal adenoma that we have to encounter. And these are the validated classifications. Practically, they come from Japan, from the Eastern country, because they have went a lot of publications and a lot of data about this. This is the most one of the most easy to use in everyday clinical practice. The NICE classification practically it divides colorectal adenomas in 3 types. Type 1 is the hyperplastic polyps. You don't have to do anything about them. Type 2 is the classic adenomas. You can remove them by the classical snare, for example, if you are familiar with that. And type 3 is the deep submucosal invasive cancer. So these lesions should be probably referred for surgery. Pros and cons of this particular classification: it is relatively easy to use. Another classification is the Sano classification. This helps us, of course, distinguish lesions that have deep submucosal invasion and should be referred for surgery, and it has a great diagnostic accuracy along with high sensitivity and specificity. Perhaps one of the most validated and used in everyday clinical practice is the JNet classification, which demands magnification and use of virtual chromoendoscopy. Practically, we have three, again, major categories, where type 3 is the deep malignant potential, and this lesion should be referred for surgery, while all other lesions are the colorectal adenomas or hyperplastic polyps, so they can be treated accordingly. And what we see is that, of course, for type 3, this particular classification has very high numbers of diagnostic accuracy. However, for the intermediate levels, for the adenomas, it doesn't refer so good. And finally, the Kudo pig pattern that came from Japan. This is practically very cumbersome to use in everyday clinical practice. However, those who are familiar with it and use magnification endoscopy and chromoendoscopy know that, for example, Kudo pig pattern 5, either 5.1 or 5N, is deep submucosal cancer, so you don't have to treat this. You just place a tattoo, for example, and you send it for surgery. The good thing is that, again, for variables that come for pig pattern 5, we have high diagnostic accuracy. For the intermediate categories, there is another problem. So, okay, these classifications are there, we know them, and they're in the bibliography. So how to use them in everyday clinical practice? This is a standard procedure, what we should do at least when we see a colonic speck. You can see here in the video here playing that we have a large lateral spreading tumor that comes in transverse column. So the first thing what we do is that we get a macroscopic look of how this adenoma looks and how it extends. Perhaps we can also describe and give details about the size, and then we go closer. We use the chromoendoscopy, and then we use the magnification endoscopy in order to see potential details that will allow us a deeper estimation. And in most cases, we also use water, because water during endoscopy gives a nice natural magnification effect. So it is an additional tool that we use in order to see how this lesion can be approached and then treated. And then we have a similar lesion that comes in situ. It is a lateral spreading tumor without a granular type. But as you see, as we go and we start lesion assessing, of course, we take particular attention to see the other anatomical landmarks, because it will make potential excision much more difficult. And what we will see here in the chromoendoscopy is that the polyp, the adenoma, has its in center. It has deteriorated pig pattern, and in the magnification, it seems that in the center there is potential invasive carcinoma. And in the final, this is a rectal sperm, where you can see it's not so big in size. It is at least 2 centimeters. However, after the initial assessment that we see, the macroscopic feature, we see a deep ulceration in the center of it. And when we get closer with the use of water, and then we change with a chromoendoscopy, you will see that in the center there is a large distorted area of the pig pattern. This is deep submucosal cancer, and this, of course, will change the way we will approach this particular patient. So lesion assessment, and it's not so simple, and we should use it in everyday clinical practice because it will change the way we approach these lesions. So perhaps about the future, AI is here to help us, but these are all the data from the studies that are available currently about the use and the potential prediction of AI in the depth invasion of colorectal cancer. What you will see when you learn and when you go through the studies, that artificial intelligence will currently help those who are non-experienced endoscopists, but it will not help experienced endoscopists advance and perhaps identify more lesions. And the specificity and sensitivity of the lesions are largely variable because we have different studies from different sizes and from different endoscopists. So this is the diagnostic algorithm. When we see SPERC or SPERC, the first type, of course, is to take a good look with white light endoscopy about morphology, size, location, and of course the gross morphological malignant features, like we said, using the Paris classification. The second step is go closer and use the chrome endoscopy just to identify potential features like the NICE-3 classification and local ulceration that can mean deep submucosal invasion. If none of this exists, then we go to the third step and we go and magnify and use chrome endoscopy just to make a large and very detailed examination of the polyp, of the whole surface of the polyp, just to see if there are additional steps. So this is a commonly encountered question, especially for us endoscopists. What are we going to do in case we find these polyps? Should we take a biopsy or not? Well, current guidelines are not so clear about this, and really they leave it up to the endoscopist to decide whether this lesion in front of us is amenable to endoscopic removal. If the answer is yes, then you can take biopsies, but with caution and having in mind that taking a biopsy increases the risk of submucosal tethering and making potentially the next attempt to endoscopically remove this lesion much more difficult. However, if there is strong suspicion that the lesion is cancerous, then we have to take targeted biopsies, avoiding flat areas or areas at the periphery of the lesion, and just to justify the whole lesion. And when we see this kind of lesion, we don't have to take only account the parameters of the colorectal adenoma, but also polyp characteristics that come in size, in morphology, in site, and access, because at the end of the day, large lesions may be in rectum, which is, as already said, easily accessible. However, a small lesion behind the folds or involving the ileocecal valve may be so difficult to reach. So perhaps thinking that we can refer the patient just to another colleague at another day or at another hospital may be reasonable for polyps, for adenomas that they are difficult to remove. And these are the currently established guidelines from the European Society of Gastrointestinal Endoscopy and how we should approach colorectal adenomas. What you see is that lesion classification according to Paris lateral spreading classification, NICE and J-net, is of paramount importance, and it is a basic step before doing everything. This will guide the process to come and how these lesions will be treated. Just a small reminder that rectal adenomas are kindly different compared to colonic adenomas, not because only of the axis, but also because they come in larger size and because rectal adenomas can contain invasive foci. So if a rectal lesion is above 20 millimeters, we have to remove this lesion and block by current established endoscopic techniques, ESD or something like that, according to its availability of anyone. So just to conclude, and without potentially causing any other damage, all lesions should be photographed and video edited before removal. We have to estimate the size, approximately, of course, in many sizes. We have to use Paris classification, not just to include it in the endoscopy report, but because it gives very handful information regarding the potential submucosal invasion, therefore resectability of this lesion. NPI classification using NICE classification and Kudopit pattern classifications are welcome. However, they're not very easy, especially in those who are not trained to do so. Biopsy only concern about cancer when you never know about what it is. And of course, adequate planning if endoscopic resection is decided is of paramount importance. So from this last slide, from my side, what I would like to focus on is this MDT, this multidisciplinary team, and how these lesions should be today approached. And this is of paramount importance just to give our patients the best reported outcomes. Thank you very much.
Thank you, George. Maybe we'll have a discussion at the end of all lectures, but maybe you could do a short comment on the use of DICE and endocytoscopy for assessment. which is asked by one of our attendees.
Very nice question. Thank you very much. Well, you can use dye endoscopy. It's very useful and you can use it. But nowadays we have virtual chromoendoscopy at the touch of our hand in most of endoscopes. And really, this virtual chromoendoscopy has shown very good results compared to the classic chromoendoscopy. As far as endokitoscopy is concerned, you can use it, but it is very technologically advanced and the training is very demanding to provide these good results. But if you have it, you can use them. And of course, it will provide a more in-depth view of the polyp and the pit pattern of the colorectal adenomas.
Oh, John.
I will make a short comment. Excellent presentation by Dr. Giadzios, and highlight the important role of technology, how much it helps us in establishing an optical diagnosis. I like very much the algorithm and the steps towards the diagnosis and of especially the deep invasive lesions. I think it's important sometimes, as he mentioned, to think twice before attempting to excise these lesions. And it's important to document them and discuss them and come on another day by another clinician, another hospital. I think that's a very important message. Thank you. Thank you for the presentation. Excellent. So, Konstantina, shall we proceed to the
Yes, please. Yes. Thank you. Thank you very much, George. Excellent presentation. So, please, George.
So the next presentation is from Gina Brown, Professor of Gastrointestinal Imaging at the Imperial College of London, UK. Professor Brown has sent a pre-recorded presentation just to avoid issues with connection, and she will join us live at the end of the third presentation after the comment of Professor Hill in order to answer questions. So can we proceed to see this pre-recorded presentation by Professor Brown, please?
Θέλετε να ξεκινήσει?
Θεόφιλε, ναι. Να ξεκινήσει.
Thank you. In this talk about staging rectal cancer, I'm going to cover how we recognize lesions suitable for rectal preserving approaches using high-resolution MRI. I think a lot of people, since the advent of more use of total neoadjuvant therapy, think that the only way of organ preservation, i.e. sphincter preservation, is to give patients preoperative treatment and then look for a watch and wait approach. However, there are a number of lesions, particularly early rectal cancers, for whom this approach is not effective, and a much better way of doing this is to look carefully at an early tumour and determine if that patient could be suitable for local excision. The role of the early rectal cancer MDT is to get the maximum information before a procedure is done. So that involves gastroenterologists, surgeons, pathologists, and radiologists working together to assess a particular risk for recurrence, but also to think about how a patient may be offered opportunities such as local excision and surveillance instead of either primary surgery or chemoradiotherapy. as the primary treatment for an early tumour. So the key to early rectal cancer staging is to make sure that patients have high quality images. And this means that you need to have an approach that allows those images to be good quality, but also the interpretation of those is important. When we look at some of these historic papers, we find that most of those patients with early rectal cancers were overstaged, and a lot of the MRI techniques or the staging techniques that we use were suboptimal. Endorectal ultrasound has been previously considered to be a good technique, but it's not been found to be that accurate, and in particular, it is poor at assessing disease within the mesorectum. So how can we make sure that all patients have access to high quality, accurate staging? And what can we do about making sure that there is an approach to identifying patients suitable for local excision? We previously published a paper showing that when we assessed the degree of preservation of the layers of the bowel wall, this was a much better way of staging these tumours. And in a group of patients which had gone to primary surgery with less than T3C tumours, i.e. T3A and T3B as originally staged, we found that we could identify with 89% accuracy those tumours that could potentially have undergone a local excision because there was good preservation of the muscularis or the submucosa. So we are now in the midst of a prospective study called the PRESERVE trial, in which we are in a multi-centre study with multiple radiologists looking to see how we firstly can prevent the overstaging of lymph nodes, to avoid underestimation of discontinuous vascular invasion, preventing overstaging of early rectal cancer, and providing surgeons and gastroenterologists with a clear roadmap of the lesion so that they avoid what was previously conducted as sort of freestyle local excisions, which had destroyed the TME plane and resulted in catastrophic recurrences after a local excision. So this is all about increasing precision and using the roadmap of MRI to help to increase that precision. We will be looking at patients who have high-risk features, who then subsequently have TME and find that there is no residual tumour in the specimen, because those patients in the future could be offered a surveillance approach. So one of the main things that we have recognised amongst radiologists is the tendency to overstage lymph nodes. And very often you find radiologist reports indicating that they're measuring the size of the lymph node to determine if it's malignant or not. If you do that on high-resolution scans, you end up overstaging almost 40% of the nodes. They end up being overcalled as malignant when in fact they are benign. So it is a really poor way of assessing patients' the disease within the mesorectum. So here's an example of a lymph node that's enlarged, but it's benign. And so size and whether or not a node is malignant has no relationship. But on the other hand, if you don't do a high-resolution sequence, you might miss disease beyond the primary tumour. So here's an early rectal cancer. The muscularis is fully preserved. But when you look at the high-res images, so that might be that previous view would have been that of just the rectum. But if you actually interrogate the whole mesorectum, you'll see that the patient has multiple tumour deposits, which would preclude any kind of approach that involved local excision. And this patient, in fact, needs preoperative treatment and TME surgery. Likewise, here's a patient who was assessed by ultrasound, and they had a local excision. The local excision was completely clear, and margins were clear. But at the time of staging, they have not had an MRI scan, and therefore, this focus of the MVI, which is far away from where the original tumour was missed. And so this patient ends up with a recurrence because they weren't staged with MRI. They were only staged with ultrasound. So there is a risk of relying on ultrasound to stage early rectal cancers, and that is the missing discontinuous vascular invasion and tumour deposits. Here's another example where you've got a tumour deposit beyond the rectal wall and far away from the original primary tumour that was locally excised, and this kind of disease should not be missed by MRI. So how do we stage these tumours? We have to think about the layers as being quite distinct, and you can visualise them on the high-resolution MR if you take the trouble to do a good quality scan. And what happens is when you do that high-quality scan, you can see all the different layers of the blood wall. So you can see the black stripe, the two black stripes of the inner circular muscle and the outer longitudinal muscle coat, with their preservation indicating that this is a superficial tumour. And in fact, you can see this white line here, which is the submucosa. So it tells you this is a really superficial tumour and that local excision would be feasible. So that's the premise of the PRESERVE trial, is training radiologists to look for these features and making sure that they understand that they're dealing with an early rectal lesion. So we have provided a template for the radiologists in the study. They will be looking at the morphology, the diameter and the thickness of the lesion to provide the surgeons and gastroenterologists with a roadmap for final local excision, if that is what's decided can happen. Things that we think have been helpful to the endoscopists or surgeons have been locating the stalk, if there is a stalk, locating the central invasive portion of the tumour if it's a flat lesion, and measuring not just the craniocaudal but also lateral extent of the tumour and its invasive border, so that we can have an estimate of how much of the quadrant of the rectum is affected, and therefore whether or not it would be feasible to do a local excision with preservation of the rectum as a whole. We look at the nodes, but we mainly look for the presence or absence of vascular invasion or tumour deposits as vascular and discontinuous spread. And then we also assess the height and the quadrant that the lesion is involved in. So the technique requires 4 acquisitions, a small field of view, and a high matrix. The combination of the field of view and matrix gives us the kind of resolution that is required. We do not recommend using diffusion-weighted imaging because it doesn't improve accuracy. It has a poor resolution and poor specificity. And what's really problematic is that it reduces the time available to do the proper high-resolution scan. So that is not really a helpful sequence, but the high-res T2 weighted sequences are the most useful. So that gives you the parameters, which is that we get a 0.6 by 0.6 pixel size with a 3mm slice thickness. That gives us the 1mm key voxel. I see a lot of scans that are 3mm thick, but the pixel size is poor because what they have done is undertaken a scan with a very large field of view, and so it's not really high resolution. So the important thing is to make sure that the coverage is only at most 20 centimetres in each plane. So that's the important features, and that actually the other important thing is to make sure that there's adequate coverage of the whole of the mesorectum. We encourage radiologists to look at all the different layers, to look for the submucosa, to look at the muscularis, and then also to see if the full thickness of the muscularis is preserved. And they only need to see that on one view, and that prevents us from having this problem of overstaging. So the other important thing to remember is that a T1 that's through the full thickness of the submucosa compared with something that's only just a millimetre or so into the muscularis probably are the same prognostically, and both are potentially amenable to TEM or a TAMIS procedure, as long as you have a millimetre of muscularis preserved. And so these patients in the future might be the ones that you could offer a local excision for. So here's the high-resolution example. You've got the mucosa, submucosa, the circular and longitudinal muscle layers, and this is something that you should be able to achieve on the kind of high-resolution protocols that we have encouraged in the PRESERVE study. And here's a zoomed-up view showing the sort of characteristic stripy pattern of the submucosa and the layers below. So it's quite easy to estimate if those layers are intact or whether they have been disrupted by tumour. So in terms of the study, we're going to be looking at all tumours stage T3B or less. That means patients going to primary surgery will be staged using the PRESERVE proforma, and then we'll be measuring how accurate we were in estimating the degree of preservation of the muscularis propria. That's the end point of the study. It involves recognising the anatomy of the rectal wall, including the submucosal fold pattern, muscularis, and it also involves having a very set method of locating the tumour, describing the tumour, looking for the invasive border when you have a flat tumour, and looking for the stalk when you have a polypoidal or villous lesion. So here's an example of the sort of flat tumour that we're going to see with the raised rolled edges in the central depressed portion, and that's the area we focus on when we're staging these tumours. And if I then show you the MRI of these sort of patients in the next slice, the drill is that we locate the central ulcer crater. We ask some questions. Is the submucosa visible? If not, is the muscularis visible? If not, how much is not visible? And if you are saying that the tumour has invaded through the full thickness of the muscularis, i.e. it could be an early T3 tumour, this needs to be seen on both orthogonal views because it's quite easy to overstage. Unless you see it on two views, it may not be a real phenomenon. So here's an example of that kind of thing that can happen. So here on the axial view, you might be concerned that the muscularis is partly involved here, but in fact on the sagittal view, it's visible in its full thickness as well as the submucosa being preserved. So that means actually it's a T1 lesion, and we can see that underneath that lesion there is intact submucosa, and the only thing that's attaching the tumour to the rectal wall is the stalk itself, which is of low signal intensity. So for polyps, we look at the convex surface, we look for the stalk and the clock face, and we look to see if the submucosa is visible. Same sort of drill as the flat lesions. Here's another example. We've got a polypoidal lesion. You might just be able to see the stalk, but what you can definitely see is at the base of the lesion, the submucosa is intact, so is the muscularis propria. So this lesion, even though it's quite bulky, is suitable for the local excision approach. Here we've got a tumour with razor rolled edges and a central invasive border. The muscularis is intact, and that same feature is visible on the pathology. So we also encourage the radiologist to look for vascular invasion, making sure that we're not missing potential sites of disease relapse, even though the primary tumour is confined to the rectal wall. So following the vessels that are draining the tumour and checking that they don't contain tumour signal is quite an important thing, and making sure we don't see any tumour deposits. So here's an example of what we mean by that. So this is well above where the tumour has been. You've got normal rectal wall, normal submucosal fold pattern, and yet there is this tumour signal and the signal void of a vessel. So that is a tumour deposit, and it's sitting on the mesorectal fascia. So this patient, even though they might have had an early rectal cancer, would not be suitable for local excision because there's disease extramurally within a vein and abutting the TME plane. Likewise, here we've got an example of an early stage tumour. It's polypoidal, but maybe there's a slight central ulcer crater that could have been amenable to local excision. However, there are tumour deposits present, so this would not be suitable. So that's a kind of summary of how we stage these tumours and what the sort of features we look for, and that gets into a report, and we provided all the radiologists and Preserve with a template to help them look for those features and to structure their reports accordingly. And this is an example of how that might work. You can see the tumour, and we can see that the submucosa is intact, apart from here where there is no visible submucosa, and so the tumour might be involving the full thickness of the submucosa and potentially a small area of muscularis. And in doing so, we can produce a report which gives us that information. We can also give the height, the quadrant, and all that information to help plan the treatment. And in this patient, they did undergo a local excision. The tumour was just focally going into the muscularis, but on final pathology it was PT2 with some vascular invasion. So there is a risk that a patient would have a relapse, but it's not guaranteed. And 80% of those patients, they wouldn't get any kind of relapse. And we can prevent that possibility by undertaking surveillance. And in a few patients, many of them were offered adjuvant radiotherapy to prevent relapse for high-risk features. So here's an example of a patient who had a local excision, and 3 months later, there's just the scar, and we can keep monitoring that, and that's what we did for 5 years, and that patient never had a relapse. And likewise with this kind of case, these quite low tumours are the ideal ones for local excision if you can see preservation of the muscularis. So here's another example of the lesions that we can stage as early rectal cancer. We can see the submucosa here, and you can see that exactly aligns with the final pathology. So here's another example of early rectal lesion on the stalk, submucosa preserved, suitable for local excision, and the final report there indicating that correlation with the pathology, which was pretty precise. So I think the discussion with the patient after you do a local excision for an MR identified early lesion can be quite important. And when patients are presented with these options, which is completion, anterior resection, chemoradiotherapy or surveillance, very often they can opt for surveillance followed or preceded by chemoradiotherapy after their local excision. So that often is what patients opt for, and the results of the recent TESAR trial suggest that that would probably give very good results and equivalent to that of having major local anterior resection in the first place. So here we've got examples of the follow-up that you see in such patients and how easy it is really for us to pick up a recurrence if a patient does have one, and the fact that probably that any recurrence that we see could be easily retrieved by completion TME surgery at the time that they get their recurrence. So in closing, I just wanted to just share you the data from a study that's just been published in Endoscopy about teaching other radiologists how to stage these early tumours. We did a half-day training session with these radiologists, and their accuracy for staging early rectal cancer improved from 29% to, in fact, an accuracy of 80%, more or less, equivalent to the central reviewing radiologist. That the important thing is that they could identify those patients who could have enough muscularis preserved to have a local excision, and in a way, it allows patients to have this first option prior to any further and more definitive treatment if that becomes necessary. So recognition and staging of early rectal cancer is possible, and using this template, we think it is possible to improve organ preservation through better staging. And so we're going to be testing that in the PRESERVE trial. So it's worth noting that when you give radiotherapy to these patients in the hope that you might get a complete response, you don't really achieve that in the majority of patients, because what then happens is half of them might regrow, and you end up perhaps benefiting only a minority of the patients that are selected for this kind of approach. So it's not a good idea, I don't think, for early rectal cancers to be irradiated. Whereas if you do a local excision in these patients, most of all, the majority of these patients achieve organ preservation, and only a fraction, maybe less than 20%, require surgery after surveillance because of regrowth within the excision scar or a deposit within the mesorectum. So in other words, this is going to be much more likely to succeed with long-term organ preservation than an upfront chemoradiotherapy approach. So to conclude, early-stage tumours are well evaluated using high-resolution MR, and the use of ultrasound is really, I think, only should be reserved for the very, very superficial lesions that are not for TME or TEM rather, maybe those for EMR or something. I don't think it's going to be very useful for actual invasive tumours. The technique of the MR is important, and we are going to be giving the results of the PRESERVE trial probably in a year or so, when we've completed the study at approximately 20 centres that have enrolled into it so far. Thank you very much. Thank you. Can this talk about...
Thank you very much, Professor Brown. I think Professor Brown has joined us.
And we hope that, welcome, Professor.
Thank you. Can you hear me all right?
Yes, yes. PRESERVE trial launched how long ago, and how long is going to last?
Those are good questions. So some of you might be familiar with UK research departments nowadays, that they're not the fastest at reacting to new trial protocols. However, it's taken about a year to get everything going, but we are open now in more than 15 sites. At least 2 sites have completed, or more than that, about 3 or 4 sites have completed the control phase. 1 site has completed the entire control intervention and post-intervention evaluation. So I think in about 12 months from now, we should have most of our data in. So we'll have an idea about how the radiologists are doing with this new template for reporting early rectal cancers.
Obviously, this needs training the radiologist. So the idea is really to help with the accurate staging of these lesions, and also help the decision making at the MDT.
Correct. And you know, we're not going to interfere too much with the decision making in the MDT. We think that will happen naturally when we improve the confidence of radiologists in showing what they're seeing as early rectal cancers. So the primary endpoint of this study is simply the correlation between the imaging prediction of preservation of the muscularis and the final specimen, and the pathologists agreeing with that. And what we think is that certainly understaging has no particular consequence because most of these patients are going to have primary surgery anyway. But overstaging also doesn't have much of a consequence, because if you do a local excision and it turns out to be more advanced, as long as the local excision has not been too aggressive and not gone far out into the mesorectum or disrupted the TME planes, there is nothing lost. The patient would still go ahead with whatever they originally planned for in terms of the primary surgery. So these are the sort of things that we're going to be measuring in an observational way, just to see if those thoughts are actually correct. Nothing like this has been done yet, which is surprising, that nobody has systematically attempted to identify these patients and then track what happens to them. So I think the information from this trial will help to advance other studies that are specifically trying to find these early rectal cancer patients for the new platforms of local excision that are widely available now, as well as other new techniques like intramuscular dissection, which preserves longitudinal muscle coat. So this will all be very interesting in terms of how secure we can be with the information we give in a multi-center setting with non-expert radiologists, but who are interested in GI, reporting these cases.
Okay. I can see the advantage, which is the eventual advantage is increasing the organ preservation rate, as this was shown as well at the DCR paper by Basingstoke, which I showed in my presentation. And of course, per the patients from the functional mishaps following major surgery or radiotherapy. I will actually ask at this point if Konstantina has no objection on that. I will welcome a comment from Professor Hild, just to comment really on this new concept and what is his view, but because I think it's important. Is this okay, Konstantina?
Yes,
well,
please.
I haven't left. Gina and I are very good friends, and I'm the guy who started the colorectal outfit in Basingstoke, which is about just over half an hour's drive from Heathrow, due south, in case anybody's trying to locate a place they've never heard of. But I went there a very long time ago. And when you say the new concept, which of the new concepts are you asking me to comment on at the moment? There are several new concepts, and,
sure.
Which I'll try and summarize at the end. But which exactly are you asking me to comment on at this moment?
Essentially, the introduction of more local excision as compared to radical surgery, and in order to have high preservation rate, organ preservation rate, and avoidance of neoadjuvant chemoradiotherapy or ETNT.
Yes, I was once asked, these are big questions, and you have, I think, to understand the background history, really. And it's interesting to me to start by saying that nobody has mentioned the value of the index finger. And Gina has never been interested in the value of her index finger because she is a brilliant radiologist. But the surgeon, the person who usually sees, or used usually to see these people first, learned a great deal from what I call the bioprobe, his finger. There's a huge amount of information available from that. The mobility of the tumor on the underlying muscle. With more advanced tumors, the mobility of the tumor in relation to the prostate and so on. The detection of a polyp stalk and the ability to move the polyp around within the lumen. All of these things are, I think, something which needs to be taught to everybody who does a colonoscopy. And this is where not everything has improved so much. There are so many different concepts you might be asking me to touch on. I believe pretty much everything that Gina tells me, but I'm all too aware that you need one of your radiologists, or maybe two in a big hospital, to take a special interest in your MDT, whether it be a significant rectal neoplasm MDT, which Basingstoke has, a special MDT for tumors more suitable for local excision than all the, well, the T1s and the, well, it's exactly the specs that we originally described, and they are the ones where you're starting the significant polyp with the risk of early colorectal cancer. Is it safe to do local excision? In general, the idea is that SPEC identifies a group where TME or more is over-treatment. But my view, which would be not very popular worldwide, is that actually, if you learn to do a perfect TME, it's probably safer long haul for the patient with an early cancer to have an unnecessary TME than it is to have unnecessary radiotherapy. For us, you need to give radiotherapy to people who are have tumors that have either gone into their veins, EMVI, which Gina has so brilliantly described and drawn our attention to. The new baby of EMVI, of course, is the tumor deposit. That's the deposit in mesorectal or other fat with no evidence of a lymph node having ever had anything to do with it. And so EMVI and venous invasion or invasion of the mesorectal fascia, these are the only tumors I feel should go to radiotherapy. But there, of course, you have a subgroup. So we've got a lot of you've got a subgroup of people who will get to rectal preservation via having radiotherapy. But actually, if you've got an early lesion and you're not sure what to do with it, and provided it's far enough from the anal verge, you're better off to do a good nerve-preserving TME than you are to give radiotherapy because you can't make your mind up. And what you need in every specialized unit, I think, is one or two radiologists who will spend a few days with Gina or a Gina-like person. They're all, I'm sure you have many in Greece, who will be happy to teach all the things she's talked about. I think, as I say, there are so many overlapping concepts here. Over to Gina, or back to Gina.
Sorry, Dr. Theodoropoulos, can you switch off your audio, please? Sorry, Professor Hill. Dr. Theodoropoulos. Sorry, can we switch off the audios, please? Sorry about this.
I mean, it's a big discussion, but these are the lesions. As I say, I don't want to repeat myself, and I think we all need the quality of MRIs that Gina is trying to teach us. And if we have that, then we have the most valuable way of sorting how to manage the tumors that we assessed with our initial endoscopy and rectal examination as being possible SPECs.
Well, thank you very much for this comment. Yeah, sorry. I think that's why webinars are nice, because there's debate. And thank you very much for giving us this debate. And thank you very much.
You asked me to address a concept. Which of those concepts were you really wanting me to address, or has what I've said been?
Sure.
Okay.
I think it's a great debate about local excision and TME and also TNT, and I think that's why MDTs are great, because we can hear lots of opinions and decide at the end, and the decision is made based on the clinical situation as well as the fitness of the patient, because not all the patients are fit for surgery, and some of the patients are fit only for local excision. And also, at the end of the day, as well, is what the patient wants after you present all the data.
Yeah. And interestingly, I have been recently on something called, well, you can access it if you want, but it's called on-air robotic surgery, and we went across the world in one day, starting in Korea, and working our way across Europe and the UK, and ended up in America. And in America, 80%, we were told, in Philadelphia anyway, of people were with rectal cancer were getting TNT. In other words, they were getting chemo and radiotherapy plus extra chemo. And at the other end of the world, there was certainly less than 50%, and many down to 20%, depending on where you arrive. So this webinar is really very relevant, because across the world, nobody is making their minds up which are SPECs, which can be removed simply locally. And the solution, I think, has to come from MRI and its developments, and even the protocols for better and better resolution with MRI are being worked on. So that I do believe imaging is the solution, but we should not forget the old-fashioned finger, which hasn't, as I say, even been spoken of except by me.
Absolutely. I think we should welcome our third speaker, who is waiting to deliver his lecture, Professor Nick West, Professor of Gastrointestinal Pathology at the University of Leeds. Nick, thank you very much for joining us today. It's a great pleasure, really, to have you here, and we're very eager to hear your talk.
No problem. Thank you very much for the invitation. Can you hear me clearly and see the slides?
Absolutely.
Yeah. Okay. So it's a real pleasure to speak about the role of the pathologist in the treatment of significant polyps and early rectal cancers. In the UK, at least, we have a prescriptive data set for recording cancers, early cancers removed by local excision, whether by polypectomy, EMI, ST, TEMS. And that's been the case for a number of years now. We've had a major resection minimum data set for many years, but for at least the last 8 years, we've had a separate data set for early cancers removed by local means. And you can see here, this is the most recent version published in April 2023. There are certainly in excess of 20 individual data fields relating to the clinical context, the macroscopic description of the specimen, and the histological features. And within the UK, if the lesion is resected as part of the national screening program, there are some additional guidelines to support the reporting of these lesions, which also extends to adenomas. And we've also got European guidance, which is generally in harmony with the UK guidance. The first question we really need to ask ourselves is it really cancer if we see neoplastic cells extending beyond the muscularis mucosae into the submucosa? This is a pedunculated sigmoid polyp, and we can see in the center of the polyp that there are neoplastic cells within the submucosa. And this is something that's frequently misinterpreted by pathologists, particularly general pathologists who are not trained in the pitfalls of these specific lesions. This is misplacement, artifactual misplacement of low-grade dysplastic epithelium into the submucosa due to torsion of the polyp. And when we performed a review of early cancers resected in the National Bowel Cancer Screening Program in England, around 10% of those cancers had been overcalled. They were actually adenomas, often with low-grade dysplasia with epithelial misplacement. So the screening program in the UK set up an expert board which offers local pathologists the opportunity to send in challenging cases for review. And here you can see some of the recent data from the expert board, where the majority of cases that were sent in with a favored diagnosis of benign from the local pathologists, the expert board agreed they were benign. A small number were upgraded to malignant. Interestingly, the polyps that were assumed to be malignant by local pathologists, 50% of them were reclassified as benign by the expert board, again demonstrating that pathologists often overcall these advanced adenomas as early cancers because of a misinterpretation. And we do get a number of difficult equivocal cases. Sometimes even the expert board can't give a definitive answer. And this is why for over 10 years now in the English screening program, we have mandated that any new polyp cancers be reported by 2 independent pathologists to confirm that we are definitely dealing with a cancer. So if we move on to look at the high-risk features that we should be reporting in early cancers, I think hopefully you'll all agree that these are predictors of a poorer outcome. So the maximum diameter is maybe debated as to what exactly the cutoff is for higher risk. But generally, we've gone for 3 centimeters as defining a lesion which is unlikely to be resected by local means. But certainly that threshold is debatable. And there are certainly larger cancers that can be resected with a clear margin via TEMS and local excision. Margin involvement is, again, another contentious issue. We've to date carried forward the 1 millimeter rule as applied to the major resections into local excisions, but there is some good evidence that we could potentially relax that 1 millimeter margin to something less. Poor differentiation, lymphatic invasion, venous invasion, tumor budding, and a depth of invasion into SM3 or beyond are generally considered high risk. And any one of these features would generally favor a conventional resection, although I think there is some margin for debate in some MDT. Certainly our MDT in Leeds wouldn't necessarily press for a resection if the only high-risk feature was an involved margin, but where there was more than, say, 0.5 millimeters of clearance. So I think the individual context needs to be taken into account. And of course, all of these features are predictors of lymph node involvement, which is why conventional resection is preferred. And we're aware that there are multiple studies in the literature which have brought together a number of these different high-risk features to create risk tables. This is from Simon Bach's publication back in 2009. And you can see clearly the local recurrence rates are significant once you start to have a deep invasion into the muscle or beyond, and with lymphatic invasion and a significant tumor size. And I think it's really important that pathologists make the right call, firstly on whether something is a cancer, and then whether there's any high-risk features that might favor conventional surgery, because we recognize that there is still an increase, a high rate of post-operative mortality. It's come down from this data, which is a few years old now, where the English 30-day mortality was around 6.5%. We're now down to less than 5%, but there's still a significant risk, particularly in elderly patients. So we need to get this call right. So how do we deal with the specimens? Well, we prefer not to receive piecemeal excisions. We do, of course, still receive piecemeal EMRs for adenomas, but we hopefully don't receive any cancer excisions in pieces. These are very difficult to piece together and impossible to give a definitive statement on the resection margin. If the lesion is polypoid, then we fix them intact. If they're sessile, we tend to receive them from either gastroenterology or from the surgeons with the mucosal surface pinned either to a polystyrene board or to a cork board, or sometimes inserted into plastic cassettes with a foam insert to prevent the edges from curling round. So this allows us to accurately assess the deep margin. We start by classifying the specimen into whether it's a pedunculated lesion based on having a narrow base, or whether it's a sessile lesion or subpedunculated, which is somewhere in the middle, and those are the criteria that we use when assessing. And we generally approach sessile and subpedunculated lesions in the same way. Pedunculated lesions, we will bisect them through the stalk if they're straightforward and small. Any larger lesions will be serially sliced, and we always make sure to examine each of the blocks at a minimum of 3 levels. For the sessile and subpedunculated lesions, we will again bisect them if they're small, otherwise serially slice them at 3 millimeter intervals. And we can use coloured inks to determine the individual margins if the specimens are orientated. In leads, it's not typical for a specimen to be orientated, but occasionally we do see that, and we can take cruciate slices if the lateral margins are considered at risk. The reporting of adenomas is generally straightforward. There are just maybe 3 points which are worthy of mention. Villousness is subjective, and traditionally we rely on the 75% rule. So if it's more than 75% villous, then it would be a villous adenoma. If it's more than 75% tubular, it would be a tubular adenoma, and somewhere in the middle would be tubular villous. But it is incredibly subjective between pathologists, and whilst we used to consider villousness to be a high-risk feature, it's now been taken out of the UK guidance because of the subjectivity between pathologists. High-grade dysplasia is still a high-risk feature and should be assessed primarily on architecture rather than cytology, but again is a subjective area between pathologists. And finally, the classification of serrated lesions is a bit of a minefield. We've probably improved over the last 10 years, but there are still pathologists mixing up hyperplastic polyps and sessile serrated lesions, and we know the neoplastic origin and potential for further lesion development differs between those lesions, and therefore we have put a lot of effort into the UK pathology community in terms of training in the correct classification of serrated lesions, particularly serrated lesions which are considered higher risk. Diameter of the lesion is important. For adenomas, we generally consider a 10 millimeter cutoff to indicate higher risk, and that's reflected in the British Society of Gastroenterology and ACP GBI guidance. For cancers, we generally consider 3 centimeters to be a higher risk, although that's a bit more debatable. And for the cancers, that's the size of the invasive component, not the invasive component and any contiguous adenoma. Pathology measurements are always optimal, so that 10 millimeter rule devised by St. Mark's many years ago was devised from pathology material, not endoscopic estimates. So that should be done on the glass slide where possible to the nearest millimeter, but we recognize that some lesions fragment or remove piecemeal, and therefore they should also be measured endoscopically, but there is a risk of over measurement, and we published a series of several hundred polyps a few years ago comparing the histopathological to the endoscopic measurement, showing that there's a significant rate of over measurement endoscopically. For the margins, we define incomplete resection of an adenoma as adenoma present at the margin, whereas a cancer, it's within 1 millimeter of the margin, and there is some evidence that supported a change to a 0 millimeter rule, although within the English bowel cancer screening program, they kept a conservative approach and wished to keep the 1 millimeter rule. And we need to recognize, of course, there is a diathermy zone around these lesions, and therefore, just because adenoma or even invasive cancer extends to the margin, it doesn't necessarily mean it's an incomplete excision. So we do, within the MDT, tie together the histopathological features with the endoscopic appearances, and certainly the endoscopic impression of completeness of excision. We published an interesting series of polyp cancers in Leeds a couple of years back, showing that the local recurrence rate with 0 millimeters of clearance is quite significant at 32%. If you've got more than 1 millimeter of clearance, then the local recurrence rate is much lower. And when you look at the cases in the middle, the distinguishing features seem to be whether or not the tumor extended into the coagulation zone at the deep margin. So if you had tumor within the coagulation zone, then the local recurrence rate was 18%. Whereas if the tumor was within 1 millimeter, but not within the coagulation zone, then there seemed to be no association with local recurrence. And maybe we should be moving more to a definition of margin involvement based on involvement of the coagulation diathermy zone rather than the 1 millimeter rule. Within the screening program, one of our local pathologists, who's sadly no longer with us, provided some guidance a few years ago, which recommended that when dissecting polyps, you need to make sure that the plane of section includes the diathermy zone. You need to be aware of the three-dimensional configuration of the lesions and orientation, have a low threshold for cutting deeper levels to make sure that you're accurately measuring something that is a true resection margin, and if any doubt, adopt a conservative approach and only measure to a margin that you are absolutely confident about. When we come on to grading differentiation, we use the WHO classification, generally now into two groups, well and moderately differentiated as lower risk, and poor differentiation as higher risk. This is largely based on architecture, but we know that there is significant heterogeneity, and it should be based on the least differentiated component. So any poorly differentiated component would classify the tumor as poorly differentiated. The only caveat to be aware of course, is that microsatellite instability is associated with poor differentiation and a generally better outcome stage for stage. So just because a tumor is poorly differentiated doesn't necessarily mean it's a high-risk feature. You need to interpret the microsatellite instability status as well, and that's why in the UK we now do microsatellite instability or mismatch repair testing on all of our new bowel cancers at diagnosis. Lymphatic invasion may be straightforward, as in this example here. You can see tumor cells within an endothelial line space, which is devoid of smooth muscle, but it's often not that straightforward, and that means that this assessment is quite subjective between pathologists. If you look at the lymphatic invasion rates between centers, they'll differ quite significantly, and you can use additional stains to help. This is a D240 immunohistochemical stain highlighting the endothelial cells on the lymphatic channels, and you can see this is clearly lymphatic invasion. So we have a low threshold for requesting further work to improve that reproducibility. For venous invasion, it should be tumor within a vein with a muscular wall, and this is a nice example on the H&E, which hopefully most pathologists would spot without needing to do any further work, but there is the opportunity to do elastin stains or even smooth muscle stains to highlight the vessel wall and definitively call venous invasion. Again, venous invasion is often undercalled by pathologists, is missed, and if you're looking at your major resections, you should hopefully have a venous invasion rate of in excess of 40%. If it's lower than that, then you're probably missing a number of cases of venous invasion. And within our MDT, we will correlate with the radiological impression of venous invasion to arrive at a definitive status. Tumor budding is something that's relatively new. This used to be an optional item within the college data set in the UK. In 2023, it moved to be a mandatory item for any locally excised early cancers. And we use the international consensus guidelines, which define tumor budding as between 1 and 4 tumor cells, as shown in the picture on the left-hand side there. All the arrows are pointing to individual tumor buds. So this is a high-grade budding example. On the right-hand side, you can see poorly differentiated clusters. So these are bigger than tumor buds, more than 4 tumor cells in a cluster. The Japanese have shown that poorly differentiated clusters are also associated with a poorer outcome, but the evidence is less strong, and that hasn't translated into the Western data sets as yet. So tumor budding should be counted in a single hotspot at the tumor invasive front, and you should provide an absolute budding count and a grade according to the international classification. And certainly high-grade budding with more than 10 buds per high power field is a strong association with lymph node involvement and local recurrence. You shouldn't use immunohistochemistry as a routine to do the counting, but it can be useful to highlight the hotspots if you're in any doubt. The depth of invasion is also important. We use Haggett levels for pedunculated lesions and Kikuchi levels based on the thirds of the submucosa for sessile and subpedunculated lesions, and we know there's a clear association between the depth of invasion and the risk of lymph node metastases. But they're both quite difficult to use in practice. Often the specimens are poorly orientated, or the muscularis propria is not present on the specimen. It can get dragged into the head of the polyp, which can make staging difficult, and the submucosa is a variable depth throughout the specimens, and therefore which point do you measure the submucosa and estimate the thirds can be quite challenging. It may be more accurate to measure the absolute depth of invasion beyond the muscularis mucosae. It's certainly more objective and reproducible between pathologists, and the Japanese have shown that there's a clear association between the risk of lymph node involvement and also local excision. Just some more novel insights to finish the presentation off. This is some interesting three-dimensional reconstruction work we did in our laboratory in Leeds a few years ago, looking at the distribution of lymphatics And we were able to demonstrate that the lymphatics are not actually all situated down in SM3, they're up in SM1, and they are wrapping around the fibers of the muscularis mucosae. So up at the top left, you can see the muscle is dark blue, the lymphatics are yellow. If you look at the bottom left, you're now looking down onto the mucosa. You can see those yellow lymphatics dipping up into the base of the mucosa. So this probably explains why some of those intramucosal adenocarcinomas have been described in the literature with lymph node metastases. And it developed into a theory that actually the depth of invasion is probably not the most important thing that determines the risk of lymph node metastases, but it's the overall volume of tumor in SM1. We investigated this by performing an area assessment of the invasive component rather than linear measurements, which is something we can easily do with digital pathology. And whilst the width of the tumor does predict the rate of lymph node metastases, the overall area of tumor within the submucosa was even more predictive, and it opens up the theory that actually it's not the depth of invasion per se, it's the overall volume of tumor in SM1 where you see those lymphatics that predicts the rate of lymph node metastasis. And if you have an SM1 invasive tumor which is very wide in terms of the invasive front, it may actually have a higher risk of lymph node metastasis than an SM3 tumor with a very narrow invasive front, which is quite interesting and needs prospective confirmation. And finally, artificial intelligence is working its way into medicine across the field, and pathology is certainly also included. We've opened up the door to this with digital pathology now that we scan slides as a routine. And we published this article a couple of years ago now in Journal of Pathology, where we tried to develop an AI model to predict lymph node metastases from PT1 and PT2 bowel cancers. We were able to generate a model with a very accurate area under the curve, but the most important observation from this study was potential novel insights into biology. The PT1 and the PT2 cancers that had positive lymph nodes appeared to show inflammation of the adipose tissue at the base of the lesion, which is a novel observation and appeared to be strongly correlated with the risk of lymph node metastasis. So potentially opens up some novel insights into the underlying biology as to how these early lesions metastasize. And the very final point is about the quality of surgery. Coming from Leeds and from the lab of Phil Quirk, I couldn't mention any talk on rectal cancer without talking about quality of surgery. You know all the work that Phil's done over the years with total mesorectal excision with Bill and also abdominoperineal excision, grading the quality of the specimens. Well, TEMS specimens are also subject to quality assessment, and when we centrally reviewed the specimens in the TREC trial, which was a UK local excision with short course radiotherapy trial, we saw immense variation between surgeons in TEMS specimens. So here you can see a full thickness excision with actually quite a sizable pad of mesorectal fat beyond the muscularis propria. And you can see the tumor in this case is the purple structures, for those of you who are not used to looking at tumor, in the center of the specimen extend down to the base of the muscularis propria. But we have a nice clear margin of mesorectal fat, meaning this is an R0 excision. Here's another one. This isn't actually in the tumor region. You can see the tattoo pigment there in the submucosa, but you can see the base of the excision is along the outermost layer of the muscularis propria. So this one has no resection of mesorectal fat. Here you can see towards the right-hand side, we've got mesorectal fat beyond the muscle, but in the left, we can see there are defects going into the muscularis propria. And in this particular example, it doesn't involve the tumor, but you can see that if the tumor was in that region, that would have potentially caused the excision status to be R1. And here we can see another one. This is supposed to be a full thickness TEMS excision, but actually the deep margin is on the submucosa in many parts. You've just got some isolated fragments of superficial muscularis propria, not a full thickness TEMS excision. And this is one where we have residual tumor, which is very close to that margin, I think 0.2 millimeters from the margin, and therefore has a risk of recurrence. So I think there's some room to be done in terms of pathological feedback to surgeons on TEMS quality, and that's something that we want to prospectively explore in the currently in the recent Star Trek trial that we're currently analyzing. So if you want to look at any of our clinical trials, or if you want to look at the bowel cancer screening pathology expert board cases, you can go onto our website. There's a tab there called EQA, and there's a couple of pages, one related to the English bowel cancer screening program and one showing the EU guidelines. And in the English screening program, you can go on and see some of the difficult cases from the expert board, which might be interesting for any pathologists in the audience. So I'd just like to thank Phil, Heike, Peter Ewing, Neil, and Phil DaCosta, who've all contributed some images or data to the presentation. Thank you again for inviting me, and I'm very happy to take any questions.
Nick, thank you very much. As always, an excellent presentation, and thank you very much for highlighting the importance of specimen quality, because that can influence outcomes, and it's important for the surgical community as well as for the as an extension of this thought to the gastroenterology community. I have two questions. One question is, I probably missed that, but probably you said it, but tumor budding correlates with the depth of invasion, the grade of tumor budding?
That's a good question. I suspect that there may be an association, but I don't think it'll be a particularly strong association. The cases that show high-grade tumor budding don't necessarily associate with a deeper kind of SM3 level of invasion. There are certainly some SM1 tumors that just look bad. They're just into SM1. They show high-grade budding. They show lymphatic invasion. And I don't think it's related to the depth of invasion. I think they are biologically bad. These are likely to be the cases that have this inflammation within the adipose tissue at the deep margin, which is something that is a fairly recent observation. We don't know exactly what it means, and we need to do some molecular biology to understand that association. But no, I think there are just some early cancers that are bad, and budding is probably one of the strongest predictors of a bad outcome. The reason we didn't do it consistently previously is there were just too many systems and it was confusing and subjective. Now we have an internationally agreed system that's agreed across Europe, North America, Japan. Then it's more reproducible. We all know what we're talking about when we talk about budding done by the international system. And I think it's probably one of the strongest predictors of a poor outcome in these early lesions.
Excellent. My other question is, you mentioned microsatellite instability and poor differentiation. Have you noticed any change between right and left colon? I know it's about SPERC today, but have you noticed any change between right and left side?
Yeah, so certainly you'll see a much higher incidence of microsatellite unstable tumors in the right colon. There, probably 20 to 25% of cancers will be microsatellite unstable. It's much lower on the left side and in the rectum in particular. But you will still see a higher rate of poor differentiation within those MSI high tumors. Certainly the rectal ones may well be mucinous. You may see signet ring cell differentiation, which is a poorer prognosis stage for stage. But with the traditional poorly differentiated medullary phenotype of cancer, it does tend to be right-sided, you're right, but we do still see poorly differentiated MSI high cancers in the left colon and the rectum. And it's just to make the observation that it's not, you shouldn't just look at differentiation in isolation, you should understand the MSI status. If it's a poorly differentiated tumor that's microsatellite stable, then it's likely to do worse. If it's a poorly differentiated tumor that's microsatellite unstable, then it's likely to do better. And it may do better than a moderately differentiated tumor.
Excellent, fantastic. Thank you very much. Konstantina, do you have any questions?
Well, I think that we should stop now, Yanis, although we could keep going. And I would really like it was a start. We will talk about therapy and treatment in September in the second part. And on behalf of Hellenic Society of Gastroenterology, I would like to thank all the speakers and all the colleagues that were online with us. Professor Gina Brown, that I can see, and Professor Nick West and Professor Held, thank you very, very much. And of course, my friend Yanis Viglas. It's a good start, Yanis. And Professor, of course, Dr. Diadios. Really, thank you. Yannis, you should have
Yeah,
the last word.
I think it was a great webinar. Thank you very much for, first of all, for everyone who participated tonight, and special thanks to Dr. Giadzio's, Professor Brown, Professor West, and Professor Hill for the contribution. It's a first step. I think the aim is education, first of all, and also I think we all leaving this webinar tonight with a lot of food for thought. Thank you very much.